So Crohn's disease is an inflammatory condition which affects the GI tract and can actually affect systems outside of the GI tract, but primarily in the GI tract. It can affect any part of the GI tract from the mouth to the bottom, and most commonly will affect the colon or the small intestine. It presents in a variety of ways, and it can present with abdominal pain, with weight loss, with diarrhea, sometimes with rectal bleeding. How it presents in the patient is variable depending on which bit of the GI tract is affected. We don't really know the exact mechanism of what causes Crohn's disease. It does run in families, so there is no gene which is transmitted between family members. But if you have a family history of Crohn's disease, you are more likely to develop the disease. What happens with Crohn's disease is a overexpression of the body's immune system, which then causes an inflammatory response, inflammatory reaction within the bowel, and that causes inflammation. We're not entirely sure of why that occurs. As I say, there are a variety of genetic associations, and it's also in experimental models thought that it's known that if you have animals that are not exposed to any bacteria, then they don't develop the disease. So it may well be that this is a cross reaction between bacteria that most people tolerate, but the antibodies, developing antibodies that then attack our own body. Yes. So if patients have mild versions of Crohn's disease, it can present with quite subtle symptoms such as vague abdominal pain, abdominal bloating, and diarrhea, which can mimic irritable bowel syndrome. So it's important just to make sure that patients who you think may have irritable bowel syndrome don't have any evidence of mild Crohn's disease. If there are certain features such as bleeding or weight loss, then that's less likely, but there's certainly an overlap between patients who present with irritable bowel syndrome and patients with Crohn's disease. The other common disease which Crohn's disease can look like is ulcerative colitis. So Crohn's disease can present, as I said before, in any part of the gut, but whereas ulcerative colitis is confined to the colon. But if Crohn's is confined to the colon, it can certainly mimic ulcerative colitis. That is probably not so important because a lot of the therapies for Crohn's disease affecting only the colon are very similar to ulcerative colitis anyway, so it probably doesn't make a huge difference. Because the disease can affect different parts of the bowel, the diagnostic criteria are the way it's diagnosed is slightly different in different patients. But I suppose most patients with Crohn's disease will have some form of alteration in their bowel habit, some diarrhea. So one of the easiest things to do is do a stool test called a fecal calprotectin, which is a marker for inflammation. And that's very good at excluding Crohn's disease. So if that is normal, then it is unlikely there is any inflammation in the gut. And that's quite helpful to distinguish between Crohn's disease and irritable bowel syndrome. If that is raised, or there's bleeding, or other signs that make you highly suspicious of Crohn's disease, then the colon can be examined with colonoscopy, and that's a very useful test to look at the colon, and also the terminal ileum, which is at the very end of the small bowel, which can be accessed by colonoscopy. And that's the commonest place for Crohn's disease to affect the small intestine. So a colonoscopy is a very, very helpful test to look at both the colon and the small intestine, or the end of the small intestine. When it comes to evaluating the rest of the small intestine, there are two main tests. One is an MRI or CT scan of the small bowel, which is very good at picking up significant Crohn's disease, and will exclude areas of thickening of the bowel or strictures which is narrowing of the gut, and that's very helpful to assessing the remainder of the small bowel for evidence of disease. The other option is something called a capsule endoscopy, where a patient will swallow a small pill, which then travels through the small bowel, taking photographs as it goes and transmitting them to a belt and then a data recorder. So at the end of the study, you have a video of the small intestine, and that's extremely helpful for looking for slightly milder disease where there may just be small areas of inflammation in the lining of the bowel, and it will pick up less of the disease that the MRI or CT won't. It's quite important, however, to make sure that the patient doesn't have pain before you do that examination, because if there is a narrowing in the bowel that may be causing pain, then the capsule may not pass through that area, so that may be a problem. So if there's any concern that the patient has pain and there may be a stricture, it's worth making sure that an MRI or a CT is done first to exclude a stricture before giving the capsule. In terms of other areas, in the upper GI tract, an upper GI endoscopy is helpful, although Crohn's can affect any part. The small bowel and the colon are by far the commonest.